Our biomechanical assessment of the hip. So let's just look at setup for the moment. So we have the knee flexed with the foam roller, thus the hip is in an open packed position, allowing us to get a better accessory glide of the femur relative to the acetabulum. Table height is about that of the waist, such that when the therapist crouches down, they are able to use their full body rather than just their arms or their upper body. You're going to come in circumferentially around the proximal femur. You're going to compress with both of your hands such that you take up the tissue slack a little bit. And then we're going to go into the cardinal plane. So the first one is going to be anterior to posterior glide. And the closer you are to the joint line, the more effective your forces will be. Just certainly give full awareness to your patient and ask for permission to get your hands as close to the joint line as otherwise needed, as we're pretty close to the groin. All right, let's see it. So getting into the lunge stance, take up your soft tissue slack, and then notice that we're going to use the squatting technique rather than just muscling through it with our arms in order to get an anterior to posterior glide. Great. The reciprocal of this would be posterior to anterior, where you're going to again take soft tissue slack. You can notice that the hands shift a little bit more posterior to the axis of the femur. And then we're going to be, instead of squatting down, we're going to be standing up and making sure that the arms come with the lift. There's another way that you can also look at the anterior capsule, and that's going to be in prone, which we'll show in a moment. Great. Then we're going to go medial and lateral. So the important thing about the medial and lateral is that you're going to get your forearms in line, such that the vector of force that you're applying is quite efficient. So if we're going to go from lateral to medial, we'll be using the right arm here as a guide. And then again, it's going to be a weight shift. So positioning of feet is going to be important. So go ahead, let's see it. So it's less of a rotation and more of a glide. That would be a more medial rotation that you're demonstrating now, which is fine. Okay, so yes, it would look more like that. Yep. One strategy is also using your chest against, or torso against the femur to really stabilize it. And now you're really pinning that joint, as you can then shift from right to left, lateral to medial. Great. And then the opposing shift would go from medial to lateral. So once again, you're going to get into that very same position. All right, so then the lateral glide, you're going to pin it in. We have a 3-point contact with the hands as well as the torso against the femur. And it's going to be really more of a weight shift from, in this case, shifting from our left leg to our right leg as you go in a pure glide fashion like that. Keeping in mind that the anatomy is going to be important here, such that if we came up over top, we would notice that the femur hits at an angle relative to the acetabulum. So we want to go in that same vector of force. Now going into our rotations, very similar to our same hand placement and body position. So pin the femur with all 3 points of contact. And then it's going to be almost like a side bend of the torso as we rotate from, in this case, we're going to rotate internally. So we're going to start from the outside. Yes, really nice. And again, the importance here, obviously based off body habitus of your patient, you really want to compress soft tissue such that you actually move the joint rather than just the soft tissue in the dermis. Okay, and then if we compress and now go lateral, excellent.
I'm ready.
Okay, and now we're going to go through the axis of the femur and drop down to assess the posterior capsule mobility. And notice that it's going to be important that we leverage all of our strength through our legs and our full body, One common mistake is where people will squat down and keep their hands north, and thus there's a dissociation between them squatting down and their arms, and you won't feel much of a glide. Depending on the relative size of therapist to patient, you can use one hand on top and one hand underneath the buttock. Thus, you can also feel the posterior glide as well, beyond just feeling it from the top. All right, now assessing the anterior capsule in a little bit more specificity. So you can notice the patient's position now prone. We're pinning the foot under the opposite leg such that it's fixed. And then the therapist is in a stride stance with both arms directed along the proximal joint line. And then we'll be using kind of a lunge and a lean-in technique in order to provide the mobilization.
How do you feel, Brian?
So it'd be just like this. So I'd come up right around the joint line. For me, I personally prefer to go like this, thumb over thumb. I'm gonna come in and block with my torso against his knee, and then it's gonna be a sink into the hip through a hip hinge and or mild lunge. And that's actually pretty stiff.
Yeah, it feels like it needs it.
Yep.